The chair for this session is Prof. Elil Renganathan, who can come up to the seat, and he's not just part of our steering committee of the NCCM 2024, he's also a professor of public health and policy at the School of Medical and Life Sciences here at Sunway University. Prof. Elil is also a senior international expert with extensive leadership experience and expertise in public health, global health, evaluation, and organizational learning. Over the past 30 years, he has held positions in public health with a spectrum of strategic and managerial responsibilities, including over 24 years in leadership and global roles in the World Health Organization. Welcome him. Next up, we have Dr. Feisul Idzwan Mustapha. Dr. Feisul Mustapha is a senior medical consultant in public health, best known for his leadership in the prevention and control of non-communicable diseases (NCDs) in Malaysia. His special areas of interest include diabetes, cardiovascular diseases, cancers, and obesity. At the Ministry of Health Malaysia, he is currently the director at the Perak State Health Department, responsible for the overall planning, coordination, and implementation of all medical and public health programs and activities in the state of Perak. He combines his high-level experiences in the government with active engagement of civil society and multilateral institutions. Dr. Feisul is currently chair of the Scientific Advisory Group for the Monash University Southeast Asia Community Observatory, SEACO, and he was previously a member of the Strategic and Technical Advisory Group on the Prevention and Control of NCDs for WHO Geneva. In addition, Dr. Feisul has special interest in leveraging on technology in catalyzing behavioral modification to reduce the exposure to NCD risk factors. Thank you so much for joining us today, Dr. Feisul. The following panelist is a consultant hepatologist from University Malaya Medical Center. She holds significant roles in global and regional hepatitis initiatives and is the founding co-chairperson of the WHO Strategic and Technical Advisory Committee for Viral Hepatitis, contributing to global efforts in combating the disease. Locally, she assumes the role of master at the Academy of Medicine of Malaysia, overseeing various medical specialties across the country. Actively involved in the Malaysian Medical Council, she influences policies regarding medical specialist recognition, training, and professional development. Additionally, she champions hepatitis and cancer advocacy as the president of Hepatitis Free Malaysia, reflecting her commitment to public health. Her multifaceted roles underscore her dedication to advancing healthcare both locally and globally. Please join me in welcoming Professor Dr. Rosmawati Mohammed. Next up is a scientific advisor, head of the Cancer Awareness and Professional Development Department. He has traveled far and come all the way from Qatar Cancer Society. And he is also in the following: the National Cancer Governance Board in Qatar, Gulf Federation for Cancer Control, Union International for Cancer Control, World Cancer Day Advisory Group, World Ovarian Cancer Coalition, and the All-Can International. Not only that, he is also an adjunct lecturer at the College of Health Sciences at the University of Doha for Science and Technology, a preceptor at the Department of Public Health, Qatar University, Psychology, and Social Work Master's Program at the Doha Institute for Graduate Studies, and Mohamad Medical Corporation Community Medicine Residency Program. Let's welcome Dr. Hadi.
I'm gonna ask you as kind of MC for our congresses. You have a very good public speaking skills. You need to be a minister.
So many decorated and distinguished individuals with us today, folks. So we shall start. I will respectfully hand it over to the chair of the forum.
Thank you very much. You will agree with me, it's a hard act to follow. Yeah? But we'll try our best because he's with us. Yeah. In today's complex world, and health challenges are increasingly interconnected, as most of you are aware of. And I think this Congress has tried to show that, reflect that. We have to think about social elements, we have to think about economic elements, environmental factors. Addressing these challenges, you would need coordinated efforts from various sectors of society. And one of the nice things I felt about this Congress was we were seeing people from all different sectors of society coming together to discuss about cancer. Our panel will look at how different stakeholders can contribute and collaborate to advance our collective health goals towards a healthier nation. Yeah? We're fortunate to have a very distinguished panel with us. I'm not going to go and explain who they are because that's been already done. We'll touch on key concepts that Khairy had raised as well, the concept of whole of government, the concept of whole of society, and then also concepts like health in all policies. So we're hoping that through the questions and discussion, we'll get there. We have a slightly shortened version, so I'm going to get quickly to the questions. I'd request that the panelists, keep it short and punchy. I want to start with you, Khairy. Yeah. You mentioned something there. You mentioned about your experience, but you did say something about how government can better coordinate across different ministries to help the health issues, to address health issues. Do you have anything else to add to that? What you just said?
Yeah, thanks, Dr. Elil. So when we looked at whole of government policies, I wanted my public health specialists to really understand their role, not just in terms of studying epidemiological patterns of disease in the community, but also to understand the non-health determinants of health outcomes. That was very important for me. And when you talk about non-health determinants, you're talking about social determinants, you're talking about economic determinants that has an impact on health. That's where it comes to health in all policies. Because if you want to succeed with the vision of the healthcare white paper, then you really need to look at things beyond the perspective of the health ministry. And what am I talking about? When I speak about NCDs, for instance, it's easy for us to blame people and their lifestyles. That's something that I alluded to just now. But the fact of the matter is sometimes that's the only nutrition or food that's available to them, which is not nutritious. They are tired, they're working a few jobs. The easiest thing is for them to buy some fast food for their kids because it's cheap. So we're not doing enough, for instance, in making sure there's enough nutrition security in the country so that it is affordable and accessible, one. Secondly, we have to start looking at the built environment, and that's your work ministry, your local governments, about how the built environment can also have an outcome on health, on how we design our buildings, on how we design our cities to promote better mobility, as opposed to promote highways and cars where it's very difficult for people to get their steps in every day. We have to start looking at the fundamental issue of poverty and education and tie that into healthcare. Because when someone is poor and someone is not educated, then it's very difficult for them to understand what they need to understand when it comes to their healthcare, when it comes to getting preventive healthcare, when it comes to screening, what to do if they are sick. So all these things, and you can go through every single ministry, and there will be definitely a lever of policy there that has a direct impact on healthcare. And that's what I meant by a whole of government and health in all policies approach, where it's important for the Ministry of Health, especially our public health officials, to go to other ministries and say, hey, look, can we talk to you about your ministry and what you're doing to making sure that we have a healthier Malaysia? there's a point of correction just now. I said 40,000 permanent posts. It's actually 4,000. But nonetheless, it's the biggest increase since 2016. But anyway, coming back to the point, so that's what I meant by embedding health in all policies.
Just to follow up, the processes that you set out, or how did you get to the other ministries?
Well, it's in government it's very difficult. So I told my public health officials, because in any given multi-ministerial task force, Ministry of Health will be there. I said, you must be the biggest busybody in government. That means you must get in the face of every other ministry, because health is embedded in every other ministry. And of course, I'm very careful about overreach, because after COVID, everyone thought, MOH was overreaching in so many different things. But it was important for us to continue the momentum, to say that, hey, if we had a whole of government approach for COVID, we should have it for non-COVID time as well, for other policies as well. So it's a bit of tactical maneuvering to making sure that Ministry of Health has good relations with other ministries. Ministry of Health is clear in what we want from other ministries, and to make sure that we have good stakeholder management with other ministries.
Thank you very much. Feisul, I think it's a good segue, because it'll be interesting to understand how you set about looking at the national health priorities and trying to promote that at state level.
Right, thank you very much for that, Elil. Well, before I answer that question, Elil, let me share with you. You hear now KG talking about the determinants of health. Actually, the first time I've heard him talk about it when he was still in KBS, Kementerian Belia dan Sukan, Minister of Youth and Sports. Could have been in 2014 maybe. 2014, and I was working at ministry at that point in time. And my first thought was, I wish all the other ministers were already talking about these determinants of health. So that's the first point I'd like to share with all of you. So I'm not sure who was advising him, definitely wasn't me, although I was responsible for the NCD program at that point in time. Secondly, just to reiterate, having a good master plan and the health white paper, I've heard KJ do that same pitch twice already. The first was at the policy summit that you did. If I'm not mistaken, it was in 2022, August, in PWTC. And one thing that stood out, and that's when you talk about the 5%, here's a health minister who was willing to commit time, not just for the launching ceremony, but to be with us for the longest period of that policy summit. And thirdly, to NCSM for organizing the other meeting on UHC. I wish most of you would be there, where we had all three ex-health ministers. Was you, Dr. Zul, Dr. Sizul at that point in time, and Tan Sri Subramaniam. We didn't get your camera, unfortunately. So it just goes back to my earlier point about having strong advocates. Earlier I think about advocacy. So you need your champions to be there, because ultimately it boils down to good leadership. Not just good, strong leadership. Right? Where I am, of course I have some autonomy, or limited autonomy, where I operate in the state of Perak, because we are very much centralized. A lot of policies come down from ministry, so I don't have much leeway in that manner. What I could do is more make sure that everything's aligned, and prioritization in the face of limited resources. Right? Regardless, when we talk about the working together at the state level, I do engage with the state government, and I see what the point made by KJ in terms of getting in their face. I think it's more building relationships. So spending the time, making the time to understand the challenges faced by the state government. The other excos, not just the health exco, the other excos as well. And just to share with you, in the state of Perak, the key priority is actually SDG 1 and SDG 2, poverty and food security, ending hunger, but in a way food security. And I think for step 1, once I understand where I could get in and speak the language of my stakeholder, then we'll be getting in there and to see whether we can find areas where the, what shall I say, interests overlaps, and we can have health gains at the same time they can gain what they need on their part as well, because you can't just make health arguments really with the other sector. I'll stop there.
Thanks a lot, thanks a lot. Prof. Rosma, research institutions, how can they contribute towards evidence-based policy setting?
So tremendously, so I think this is a very good actually time to really look at what is needed. So anything about trying to position the response, so in this case we want to position the cancer response. The first thing we need is data, and without data we would not understand the gaps, where to address our key action plans. So I think the main role at this time is not just research institution, and I think everyone involved in wanting to have some role in advocacy in cancer must also know the data behind what needs to be focused on. So I think that's the main thing. So here, I think what the other thing I would like to focus is that a lot of actually discussion at the Cancer Congress will say that, okay, we need to focus on cancer, but at the same time, we must not forget the elephant in the room, and quite a number of times it's been mentioned about NCDs. And we also have to think about what is the number one killer, not just nationally, but globally, which is actually heart disease. So let's look at opportunities, not just from the research perspective, but from your action plans on how we can view this holistically. And of course, being a liver cancer specialist, I would actually say that the first thing that I would need to do is not look at just liver cancer, but look at how do we address this holistically and integrate with the NCD strategies. So there is opportunity. Unfortunately, these opportunities come from data which are alarming. The first is looking at the prevalence of fatty liver disease amongst the Malaysian population. And you see, for the very first time, the National Health and Mobility Survey has included the prevalence of fatty liver disease in our Malaysian population. Alarmingly, 3 out of 10. Very similar to the glaring data from worldwide figure that 1 in 3 adults suffer from this. But what is the significance in the liver cancer field? Because we've already shown data that the majority or the fastest growing cause of HCC, not just nationally, but also at the global level, is also fatty liver-induced liver cancer. So we're talking here now, the latest data from Malaysia, 42% of HCCs or liver cancer are caused by fatty liver, and the first and has always been hepatitis B. From 60% about 10 years ago, it has reduced to only about 44%, and not because the numbers are reducing. There are some reduced numbers among those who have been vaccinated, of course, that you don't get that. But we are saying because the sheer number of the problem from fatty liver-induced HCC. So I think here the data is important. Focus on what can impact people, policymakers. And the other thing to actually really highlight again is what we saw in the preview of our latest National Cancer Registry, which was shown on Friday. They say that liver cancer is now the 5th most common cancer, rising in keeping with the global trend, which is also showing increasing liver cancer death and also new cases.
So do you feel that academia is being engaged adequately by the policymakers?
I think there have been attempts, but a lot of times you cannot wait for, say, for example, policymakers, mainly coming from MOH, for them to invite you. You have to show yourself. I mean, do this by showing the numbers, showing your publication, showing these are the ones that can impact and can reduce the cancer burden. So I think definitely, ultimately, we need to work together with the Ministry of Health to actually get the data across.
Thanks, Prof. Hadi, it's a very unique situation because we've got national perspectives, and currently in public health, global health, you speak about the concept of glocal, which is global plus local. Yeah, so that's what we are trying to achieve in this panel. So, Dr. Hadi, from your experience in Qatar, and also from your experience from many other countries, how do you think NGOs can effectively collaborate with governments and other stakeholders?
So thank you so much. It's actually, I just want to kind of reflect on the importance of first the health care white paper. I really admire this work. This is a very important, I would say, advocacy project. It's transformed, I'm sure, the life of Malaysian, and I think this is could be a successful study, could be replicated in the whole region. And I totally agree with the importance of data, that we need to go out there and share the data with the policymakers, because data is not being communicated, hidden somewhere in publication without sharing with the policymakers. It has no impact. It has no impact whatsoever. So about your question about how NGOs can collaborate with the government, first and the most important part, how NGO, they need to be the critical players of having meaningful involvement of patients in policy in policy development. So without really creating opportunity of patient voices and meaningful involvement of the patient to be part of policy making at the level of the government, all policies will be done without having not meeting the patient needs. So this is it will meet what they think it's their need, but without meaningful involvement will not have an impact. Also, in addition to work at the policy levels, let's say bring the concept public-private partnership to the government, because sometimes the government, they have also many red tape and red line. You cannot cross this. You cannot. So NGO can really bring forward public-private partnership into the let's say the healthcare ecosystem and bring it forward. In addition to community mobilization, making sure that the cancer awareness, cancer risk reduction, prevention, all community partners are involved in the let's say, not, instead of focusing only on treatment, focusing also on the risk reduction. Every entity in their place. And the other aspect is, I think we had the discussion before in the previous talk, NGO can really push the agenda that we need to look for better efficiency, because as an NGO, we really, the NGOs in a situation that they are looking out for funding. So they know how hard it is to get funding for their initiative. So they appreciate the concept of efficiency. And I think reminding everyone of equity and efficiency aspect in health initiative, that's what NGO can bring to the table. And also the aspect of, as a non-profit organization, they also work at the level of overcoming. And I think COVID was a clear example how civil society and NGO played a role with the government on sharing a cost, on improving access. So so improving access to healthcare service, better quality, that's actually expectation from the NGO to work with the government. So I think we always, the NGO is there to complement what the government is doing. It's not as a competition, as a complement. That's, you see some part of the world, the government look at the NGOs, they are just coming to take over what we are doing in education and support. This is our area, why they are getting involved in this. No, actually, we are there to complement what the policymakers are doing and helping of making sure that their program that they are implementing is being accessible by all in an equitable way, and there is no anybody is underserved or not having access to those programs.
Thank you. I think one of the exemplary aspects of this Congress has been the interaction and the collaboration across a lot of stakeholders, including the private sector. And often in public health, when you talk about collaboration with the private sector, conflict of interest always comes up. In your dealings, how do you manage that?
So that's a very good question. So actually, when we work with the private sector, we lay out our vision. This is our vision. What's your vision? And we kind of work with the private sector, and then we meet in the middle. We kind of work on a common vision, common interest, and we focus all of our activity in this common interest. It's like Venn diagram. They think of this. We think let's focus on that collaboration. And then we move it forward in an ethical way, in an area that we make sure that there is no let's say unethical perspective. And at the end of the day, the whole concept of we totally understand sometimes the commercial aspect can impact the health, but also at the end of the day, we don't need to make it like as a taboo. I mean, we can. I mean, we are already dealing with taboo, the relation of stigma of cancer. We cannot add another stigma of working with private sector. That's we're already dealing with enough stigma in cancer. We cannot add another stigma of working with private sector.
Thank you very much. Tuan Khairy, your representation of the whole of government approach was a little bit rosier than I was expecting. What kind of challenges did you face?
Whole of government or whole of society? Okay. If I'm to be very, very honest and frank. So, before I went to the Ministry of Health, I had to run the COVID immunization program as the Minister of Science, Technology and Innovation. So, although I had a very, very good working relationship with the Minister of Health, when your hand is not on the lever directly, it's tough. Because, obviously, institutionally, the Ministry of Health will be like, why are we taking instructions from another minister? This is not correct. Although those things, I think, smoothened out after a while, but it was not easy because there is ultimately in government a lot of turf gatekeeping that takes place, which I think ministers have to continue to work to smoothen out. I found that turf gatekeeping to be one of the most frustrating things in government, because I think that ultimately, if you work together with other ministries, they care about getting credit, right? So you can share the credit if that's what is important to you. It wasn't important to me, but for others it was. So I went out of my way to say that if we do something together, then we jointly get the credit. And I'll give you an example. So when I became health minister, I had to take. So by then we had a new prime minister who was very good. Ismail Sabri was very good in the sense that he devolved the decision making for all the COVID controls to a committee. Before that, it was discussed at the highest level. Can you imagine how many hours you were allowed to go out? How many people can go into a restaurant and things like that. And I sat through so many of the meetings thinking, the half the cabinet and the prime minister shouldn't be talking about this. So Ismail Sabri came in and he said to me, you run it. There's a quartet of you, 4 ministers, Minister of Defense, Minister of Trade, Minister of Health, Minister of Communications, and you sort it out. I will endorse it in cabinet. And I found that to be revelatory in a sense that he said, he owned it as the Prime Minister, but he entrusted his ministers to make the decision. And between 4 of us, there was none of us wanting to take more credit than the others. We gave each other due recognition for decisions that were made. So I think COVID was good in a sense that it allowed us to elevate ourselves beyond normal territorial turf wars. But I think obviously it's tough to do it in a non-COVID era, because people are traditionally very, very possessive of their turf. Coming back to the whole of society approach, I wish that we continue with the spirit that we did in COVID, especially with public and private sector. I think what Dr. Hadi mentioned earlier resonates with me, because every time we raise working together with the private sector, amongst some people, it is met with extreme derision, saying that, as I said earlier in my speech, that this is the slippery slope towards privatizing everything, as though there's no middle ground somewhere. And to me, it's about the efficient utilization of resources in Malaysia. Are you telling me that, 50% of the healthcare resources, which is underutilized right now, cannot be brought into the national healthcare vision? Of course they can, and the private sector wants to. There is a cost to it, but this is something that we can work out, and we were working out on the right level of demand-centric models to come to the private sector to say, this is what we believe is reasonable for buying services from the private sector. So I think these are some of the issues and challenges that we face.
Thank you. Now, our next WHO Director General Margaret Chan used to say that everybody who can and has to contribute to public health has to be sitting around the table. But she also told us that if you're not at the table, you'll be part of the menu. So I'm trying to push the health folks to be always engaged. Yeah. Feisul, your challenges as you are trying to work with others.
I'll start first with working with the private sector. I think this is not just unique to Ministry of Health. I think it's more the government. While we often talk about PPP, public-private partnership, I think the process is what I have mentioned earlier as discretionary. So, if Minister likes this company, he can work, and Minister change. So it's discretionary. It's a black box. What can be better if we have clear rules of engagement? So as even as the State Health Director, if there is such a thing in place, where there is accountability and transparency in how we engage, it doesn't have to be procurement of services. Working private sector can take many shapes and forms. But without these clear rules of engagement, with mechanism for accountability and transparency, and very clear monitoring mechanisms, make sure that, and even anyone who's inquiring can see, okay, X amount of money or X amount of resources going in, and these are the outcomes, and whether it is value for money or not value for money over time, that will be certainly something useful. And going along the same line, and this is part of the discussion on the health white paper as well, is about autonomy. We are very, we as MOH are very centralized agency, which means that even the State Health Director we have a lot of autonomy, we don't. So having autonomy for resources allocation, even human resource, full autonomy will be something which can make it easier for us to look at our own context and to see whether our limited resources, even programs. So one of the complainants earlier was that MOH is running too many programs, right? And even in the specialties as well, we're doing too many disciplines, multi-subspecialization, which comes with different set of issues. When you have limited resources, difficult decisions have to be made. Where do you allocate? And where do you scale down when it seems unfair? And I don't have that autonomy right now, the way the system is set up. And because it's about the challenges I face right now, is well, with what you read often in the social media, limited resources, limited human resources, or buildings, or equipments. And I think we can do better if we can reallocate these resources and actually focus some resources on certain centers. So even in Perak, just speaking to KJ, we have 15 hospitals, 88 health clinics, 222 community clinics. I have 26,000 staff under my responsibility. That's a lot of facilities and a lot of staff. And God knows how many programs coming down from MOH. And I used to work in MOH, and in HQ. So I know how the games are played. So I do know that as if I have more autonomy to redirect resources, that will be something useful. And if I may, just to continue from what Prof was saying about outcome of research. So this is more putting my policy design ahead, cap in my head. Data is important, but for the researchers out there, my plea to you is that I'm time poor. I don't have time. Even if your paper was published in a BMJ, even in the Nature, even if it's 20 pages, I don't have time. It is about how you advocate and again how you sell it to whoever that you are seeing does matter. If it's the minister, if it's the DG, it has to be your elevator pitch, and it is what's in it for them. So unfortunately, when you have your paper published, it's not the end of your journey, it's just the start of your journey. If you really want the people in the right places to make decisions, to act on the results of your study, to make a difference. And this is where the challenge is for some that I have encountered. The focus is too much on the research itself and not really asking the question, what's in it for me? As the person you are targeting. My lecture on advocacy still applies. You need to know what are my concerns, what drives me, and that if you could figure that one out, then most likely the policymaker will make full use of the findings and would want to play or work with you to optimize that, because unfortunately we don't just make decisions based on facts or data. There are other things that comes into play in decision making, especially in policy making.
Thanks a lot, Feisul. Since coming back to Malaysia and joining the university, one of my mantras has been evidence, policy, practice. And most of the universities spend time on evidence, and they are circling around the evidence. They need to make sure that it, goes on to policy, and that goes on to practice. Prof. Rosmawati, how do we engage communities better in decision-making, policy setting?
Sure. So I think we will actually have to possibly the lessons learned from hepatitis C would be the best way to actually look at it. Because the success story in hepatitis C, when the curative treatment of direct-acting antivirals were available, it was cheap because it has not just generic, the voluntary licensing has meant that you can get a cure with just 3 months, with just around 1,000 ringgit Malaysian. But although we are very good, we managed to get access to the treatment in the hospitals. In the community level, that's not happening until later. And even then, it's not scaled up. Because I think one of the best effective response, if you want to see it happening in a big way, it has to be decentralized to the community with the primary care physicians and with community champions. So what is the main lesson learned here is just look at again the Egypt, which managed to cure millions of people with hepatitis C within a very short period of time. So their focus is actually building capacity, not just on the treaters, the whole spectrum in the continuum of care needed for that hepatitis C treatment to happen, which means from diagnostic to testing as well as to the treatment, and then see how this can you build capacity at the community level. So similarly for cancer, we need to think about a way to actually do this task shifting to the community champions, starting with the primary care physicians, but others as well. It doesn't be restricted to doctors. So one of the best way to show this is, again, when I want to give an example, I actually can tell that the inclusion of screening for fatty liver disease, for example, in the type 2 diabetes clinical practice guidelines, has actually put fatty liver on the radar of people other than the hepatologists or the gastroenterologists. Now, everybody needs to know. So your champions here are going to be champions, not just liver champions, they're champions in an interconnected area here. So here, this is the way we need to do things. So first of all, we're talking about this as an NCD. We also will have to highlight that it not just you're not just picking up fatty liver, you're going to pick up those who are at high risk by doing the liver disease stratification of developing two things. One is liver cancer and cirrhosis and its complication. The other is also those that are high risk of cardiovascular disease and death and other malignancy as well. So basically here, this can be done very cheaply using a free model of building capacity. I gave a talk yesterday on how we can use the ECHO model, which stands for Extension for Community Healthcare Outcomes, which is a free transformative initiative using just simple Zoom platform, but with other caveats. It's using the 4 principles of A, amplification, where you build capacity by connecting to many others in the community. Then B, by best practice sharing, by using the clinical practice guidelines, a simplified algorithm to actually get to the people. And then C, case-based sharing. So you get those who want to have this treatment to actually share with you the cases so they can master the complexity that may be involved. And D, you need a database to monitor outcomes, and the ECHO platform has got already that. So basically here we're talking about expanding access to in the entire spectrum of the cancer care continuum, which can be done free, but you must have a leader. I mean, someone to lead, at least to show this is the big picture that you want to do. What is the big picture that you want to do is, for example, for us, we look at the 4 pillars. First is one thing to strengthen the data we set. The second is early ACC detection by optimizing and scaling up the risk factors relating to ACC. Then only you can detect to prevent the ACC and at the same time have early detection at those that are high risk. But the third one also is access to a multidisciplinary team, because now ACC is not treated by one person. It's actually treated by a whole group of oncologists, interventional radiologists, hepatobiliary surgeon. Us physicians are also still very important, especially looking at the cases where treatment can even not just stop the progression of the liver disease, but can also act as a tertiary prevention for recurrence. So here, we need to get someone to look at the overall picture and see the role where the community focus will be, which is on the early detection of the ACC risk factors and preventing.
Okay, thank you very much. I want to do one last round of just thoughts and final comments from each of you. Hadi.
So, if you ask me what's my final thoughts on how we put cancer and health agenda in a better way, I think we all need to start with really advocating for making cancer and all NCD as a strategic disease. Same way COVID has been placed in all political agenda as a strategic disease, and has even as in Qatar the same thing. You know, the Prime Minister dedicated a committee, and that committee directly reported to the Prime Minister because they put COVID as a strategic disease. We need to take care of it. I think we really need to push the agenda that NCD is on a strategic disease level. That will mobilize all resources. For cancer, I think really we need to invest more in risk reduction. If you look at the balance between risk reduction, investment in cancer and treatment, there is no way to compare, like minimal investment in cancer risk reduction and high investment in treatment. So we need to reverse that imbalance, and we need to involve patient more in even at the level of research. I mean, now there is patient participatory research. Patients need to be involved even in designing research, not only like they are part of the research team. For local perspective for Malaysia and Qatar, we need to be better in overcoming cancer stigma. Cancer stigma is so strong till now in our region. It's pushing back all awareness levels. I mean, there are so many awareness levels happening, but the stigma is still very strong that is not letting people even opening their mind to listen. And definitely access to service and efficiency.
Okay, thank you. Okay, maybe you. Yeah, please go.
Okay. Sorry. Oh, fair enough. You should.
It's more time to think.
So I think looking at the title of what we actually hear today is about the role and responsibility of all stakeholders. And really, when it comes to this, we must not just think about us as stakeholders. Give a clever name. I mean, champions, maybe the other group say ambassadors in the advocacy role. But again, this must be holistic, it must be patient-centric and multidisciplinary. No more trying to say that we can do this alone. But one of the things that I would like to stress that again, when Tuan Khairy mentioned about the Minister of Health being the biggest stakeholder, so I think our advocacy role, all of us here, is really looking at how we can support and complement the Minister's Health effort in this, in reducing the cancer burden. So that's my standard.
I would say that all of us in this room have to be ambassadors, but definitely the word I would use as the advocators. This idea about these determinants of health, still a lot of people feel that it is about just lack of knowledge and awareness. They talk about choices. Yes, it is true. A lot of people have almost no choices when it comes to reducing their exposure to risk factors, because people comes in different situations. It is, and don't forget, for most of us, most of our friends are usually within the same economic strata. So what our norm is not necessarily what the norm of the more vulnerable population. So being able to have that conversation, especially people outside of health, but who are able to influence the policies relating to health, would be a very key thing for us to focus on. It is something that I focus on at my level at the state. So I do make it my business to attend almost all of the state-related functions. It's very tedious. And for a lot of people, they say, why do you go? Isn't it a waste of your time as director to go to this function which is, attended by the chief minister or attended by the Sultan of Perak? But it is where you build your relationship. They need to trust you first before they start listening to you, regardless of the message that you have for them. Right? So doing these mundane things that takes up a lot of my time is something I feel worthwhile, because it sets up the stage for me to do the rest of the work that I can do at the state level. So I'm not sure how far I can go at the state level, but when I look at my colleague in Sarawak, where state is willing to invest money in health when health is seen as a federal issue, I feel that if they can make it work in Sarawak, perhaps it's something that I can bring back to my Chief Minister, Menteri Besar in Perak and say, we do have some money at stake, perhaps you would consider doing something which is worthwhile. So I'm looking to my colleague, the Director of Sarawak, to see what she can move forward with. So yeah, I can't control what's happening in federal, and KJ has already alluded to how difficult it can be, but there is a second level of government, the state, so I'm willing to give it a shot at that level. Thank you.
Thanks, thank you to all the panelists as well for wonderful views. I want to end by giving you guys a tip, and this is to the healthcare community, especially those who are advocates organizing these congresses and symposiums. And the tip is very simple: stop inviting the health minister. Invite the finance minister. Invite the prime minister. Invite the Ministry of Economy, the Minister of Economy. And that's serious. Of course, invite the health minister. But give that platform to the guy with the money. Money matters. I remember when I was at MOH, I took 2 weeks off to go to the US to attend the ministerial leadership program. And one of the modules was how to talk to your finance minister. As a health minister, I was chosen amongst worldwide health ministers to go, and the module was how to talk to your finance minister. Because the problem is very simple. In climate change, there's a problem called the tragedy of the horizon. What that basically means is that that problem is so far away in the horizon that there's no sense of urgency to act. We don't have a COVID mindset for NCDs and cancer. You need a COVID mindset for NCDs and cancer. The health minister already has that mindset. That's why he has poor mental health outcomes. But you need to have that sense of urgency from the PM, the Minister of Finance, the guys who are holding, the ladies or the gentlemen who are holding the money and holding the resources. So next time, please invite the Minister of Finance. Thank you.
And obviously also the ex-health minister. So this has been a very rich discussion. I'm going to try to just highlight some bullets that came out of that discussion. Health is an investment. That's how we need to be pushing it, yeah? Not an expenditure. This whole concept of collaboration being crucial, building relationships, building trust, have champions, have ambassadors, have a shared vision, ethical approach, yeah? Sharing your credit. Don't always say, I did it. Share your credit. Clear rules of engagement, transparency. These are things we hear, but we really need to, make sure we mainstream these things. Evidence-based policy setting, we spoke about it. The importance of community engagement. How do we better get them involved in health decision-making implementation, balancing of priorities. Sometimes we have the possibilities, sometimes we don't. Yeah, so that's something. And as Tuan Khairy said, accountability is extremely important. Yeah, make sure we make people accountable, and also this concept of continuity. It shouldn't be that just because one health minister or one state director leaves, something is dropped. So those are things we need to think about. But generally, I think the outlook is positive. Yeah, we can look forward, and it's not as negative as things are. But moving forward, there's a lot of stakeholders working together, and a lot of opportunities to work together to make sure that we have a healthier nation. Thank you very much. I thank the panelists. And thank you
Thank you so much, Prof. Elil, and our astounding panelists today. Please do remain on stage to receive a token of appreciation. For this, we would like to invite Dr. Santari, President of NCSM, to present the tokens. First off, we'd like to give a token of appreciation to our excellent moderator, Prof. Elil. Next, to our distinguished panelist, Dr. Feisul. Next up, our panelist from the Middle East, Dr. Hadi. Up next, our esteemed panelist, Prof. Ros. And that's all. I'm kidding. We, of course, have one more. Not forgetting our former Health Minister, Mr. KJ. Not only for this panel session, but for his previous plenary session. Please, we have everyone to step down on stage for a group photo. Yes, one photo. Thank you so much, everyone.